I'm Dr. Omar Bey, and this is A Moment in Medicine. Our focus is health, education, and wellness. Our goal is for each and every one of us to have that opportunity to grow old in good health. Welcome to our show. Well, we're here one more time, and I'm so glad that we are here because it's just great to bring this topic to you. We're going to talk about interventional cardiology, and we will explain it all in a few minutes. But first, I want to talk about sharing and caring. Remember, it's all about sharing our med moments and caring about each other. And if you email me at www.medmoments.com or tweet me at medmoments, we can share all of our what happens to each and every one of us with our medical care, and that may be able to help someone else. And that's what it's all about, helping someone else navigate this maze of medicine. Alrighty. Well, I want to go to my segment that I'm starting to call Let's Talk, because I want to talk about something. I want to talk about quitting smoking. And I don't usually read, but I want to read this so we can get into this topic of quitting smoking because it's so important. Cigarettes cause so many other diseases of the body that we all need to stop if you're a smoker. Well, just think about quitting. It may make you anxious, but your chances will be better if you're ready for it, okay? Quitting works best when you are prepared. Before quitting, there's something you have to do. It's called START, S-T-A-R-T, START, by taking 5 important steps. And those steps, S-T-A-R-T. Let's go with S. Set a quit date. Yeah, you got to put it on the calendar. Make sure that this day I'm going to stop these cigarettes. They're out the door. Let's just think of it that way. T, tell your family, your friends, your coworkers, everybody that you're giving these things up so that they will know they will be there to support you. A, anticipate and plan for the challenges that you're going to have when you do stop smoking. Remember, you've been smoking for many, many years probably. It's just not that easy just to give it up like that. But you're going to do it, and with help and with friends, you can do it. Okay? Aura, remove cigarettes from everywhere. Have none in your house, have none in your car, have none at work. You got to remove them all because the temptation may be just too great. All right? And T, talk to your doctor about the fact that you are going to stop. Not that you want to stop, you are going to stop. And he may be able to help you. And the last thing I want to say is call a healthcare coach, meaning that get somebody out there that when you're having a difficult time that you can call and they can give you that inspiration to keep going. That's how you stop smoking. That's what I want you to do. Okay, so we're going to get to our main topic today. It's interventional radiology. And this, let's step back. Interventional cardiology. Sorry about that. That's the next show, radiology. Interventional cardiology. And we have the best person. I always pick the best people for topics. We have the best person to go over this topic. His name is Dr. Lawrence Mahdi, and he is an interventional cardiologist. Dr. Mahdi, welcome to our show.
Thank you, Omar. Thanks for having me on the show. Thank you.
Yes. And Dr. Mahdi, he's been on the show before, so it's not your first time.
Not at all.
All righty. And we're so glad to have you to talk over this topic because it's a difficult topic, but it's one that we'll put it this way. If we live long enough, we're all going to come in contact with this topic sometime during our lives.
Most likely.
Well, that is true. So we need to learn about it. All right? So let's step back. What is interventional cardiology? Just basics for me.
So very basically, cardiology has been divided to multiple categories. The heart is think of it as a house. It has different parts. It has rooms. We call those chambers. In your house, you have doors. We call those valves. In your house, you have the electrical system. The heart has an electrical system. That's how the heart pumps every second, sometimes faster, sometimes slower. But these structures have to work together. And sometimes these structures don't work so well. Either they get clogged up, either they get dilated. Some of the valves don't work. They get too narrow or they're leaking. So we decide to intervene, to do something about it, to make a change for better so the patient can feel better, be safer, and have a better life and live longer.
That is excellent, excellent. Now, I understand the heart muscle is a very special type of muscle. It's one of the few things in the body that never stops. How can something be your whole lifetime and never take a rest?
It's incredible, the science of the heart. It's on autopilot. It has a battery. The battery has its own pacemaker system. It's called the SA node. That's a fancy term for it. And it sits there on the upper right side, and it just fires every second, keeps going. If you have to run up the stairs, it comes up, it makes it go faster. When we're resting, perhaps it slows down. And there's no thinking about it. There's no pre-programming. It goes nonstop. Sometimes there's irregularities. Sometimes it becomes erratic. Sometimes it becomes dangerously irregular. Sometimes wants to stop. You have to do things that to change its mind and help it beat along, help it keep going. But it's one of the wonders of life.
Now, you said it fires. What do you mean fire? Is it like electricity going through, and are there channels that the electric signals follow to tell what chamber to do what, when, how?
Sure. So the main purpose of the heart is to contract in a very regular fashion, in a special way, to send the blood out of the body. So with every heartbeat, the function of the left side of the heart, and by the way, the heart has 4 chambers, 2 on the bottom, 2 on top, 2 on the right, 2 on the left. So the chamber of the heart, its function is to contract, to squeeze down, and squeeze the blood out of the heart to the rest of the heart, so the rest of the body can get blood flow, the kidneys, the brain, the legs. So we have actually the heart itself also counts on that. That contraction requires an electricity being fired in a very systematic way. So this contraction is done every second in a very regular, gentle way, not too fast, not too slow, so the blood can leave the body and supply nutrients to the rest of the organs.
Yeah, it's just fascinating to me how these chambers work in tandem, and you know, they work together so that they can allow that blood to go out efficiently. It's just a marvelous structure.
It is incredible how the doors, the valves, they know when to open. The valves they know when to close. When one chamber contracts, one valve has to close, so the other door opens, so the blood goes in the right direction. If both doors open up, maybe the blood doesn't leave the heart in a satisfactory condition. So it's almost like a precondition. Who closes first? Who closes second? Who opens first? It's remarkable.
It's really remarkable. Let's talk about some of the whole thing about interventional cardiology is that you guys do things.
We do things.
You do neat things. I'm telling you.
It can be fun.
I'm almost jealous, man. You guys get to play all the time. I love it. I love it. Let's talk about some of the things that you use to assess the heart. Now, there's EKG, and we hear this EKG all the time. What are those little squiggly lines that we see on the paper? Why are they there, and how do they help you as a cardiologist?
So the EKG, or sometimes referred to as ECG, records the heartbeat of the heart in a way that we can actually tell where the electrical system started from and where is it ending at. In that short travel, it creates certain curves on the piece of paper that can tell your doctor, the patient's doctor, is this a healthy heart? Is this heartbeat generated in a normal fashion? It can also tell you if the heart is not getting enough blood. We call that ischemia, lack of blood flow. Is there a clogged artery? We can also tell if the heart is too thick. We see that in young people who sometimes collapse playing sports. They can tell the heart is too thick, or there's something wrong with their heart. We can tell if the heart's dilated, if the heart's too enlarged, too big. Right. The doctor can pick up signals on the EKG. And once in a while, you can actually pick up a very nasty, unexpected heart attack, a very bad heart attack. And that's usually when the patient comes to the ER crushing chest pain, the doctor does an EKG. Actually can tell at that moment it's a very bad heart attack. And then the heart can be intervened upon and open up the blood flow. So the EKG is very, very beneficial. Doctors do it routinely. Primary care providers do it routinely as indicated to make sure that everything's okay. Right. Certainly if the symptom is there, it will be done more frequently but it's a very revealing test.
Interesting.
It's simply, just very briefly, Omar, simply done, electrodes are put in on the chest. Electrodes are little cups with a little bit of or little sticky tapes they put on the chest. There are 12 of them, and they basically, the number of them go on the chest, number of them go on the hands and legs, and we can actually record different signals from the heart, and those signals give a certain shape that can tell us all the information from the heart that we're looking for.
Interesting. And I think one of the most important things is the heart attack, because that can be, that's life, life or death there. You as a doctor really have to look at that EKG and say, wow, I got to move this patient. I got to do this. It lets you know that's almost like the first thing in a chain of events.
Absolutely.
That you look at.
Absolutely.
That will
Seconds
tell
count.
you.
Sure.
What's going on, and I got to do this.
Seconds count, and that EKG, the minute is seen as a major heart attack, literally the clock starts. Okay. The sooner the patient's heart improves, the sooner the blood flow is restored, the patient's specialist works on it very cautiously but very efficiently to restore the blood flow to the patient so the patient can be safe and minimize the damage to the heart.
Okay, excellent, excellent. There's another procedure that I hear all the time around the hospital. It's called an echocardiogram, or a cardiac echo. Yeah, cardiologist. Yeah, do a cardiac echo. I hear the cardiologist say that all the time, like, oh, big deal. No, but it is a big deal. It really is. Describe what this procedure is. Tell me about this cardiac echo.
So it all starts with sound waves. This phenomenon of sound waves has done a great deal of benefit to medicine. Okay. Starts with, as we had mentioned earlier, the dolphins emit sound waves, and it hits an object and comes back, and right. they can assess in their mind what that object is. So the patient comes into the doctor's office or to the hospital, and the technician prepares the chest, hopefully puts a little bit of warm jelly on the chest, and then put an ultrasound, which has a special transducer or special chemical background that can pick up, that can emit the sound wave, send the sound waves to the heart, and hits right. the structure of the heart. And the signal comes back in a way that we can again look at information. Are the chambers normal size? Is the heart muscle thin, thick, or normal size? Okay. Are the valves working well? Are the valves clogged? Are the valves leaking? Is there a blood clot in the heart? Is there fluid around the heart? So these are information that can be very valuable in treatment. And also when we're talking about the heart attack, sometimes heart attacks are not so easy to determine, or chest pains are not so easy to tell if it's a heart attack. But we can see on the echo the heart muscle is not beating well. It's becoming lazy. We can tell, oh, that may be from lack of blood flow. And again, the patient is on a very urgent basis is intervened upon or taken care of. So the echocardiogram is a sound wave, just like the one that the women have when they're expecting a child. Very gentle, generally is not painful. Very rarely they have to press a little bit to see a structure, but the technicians are excellent. They can create pictures. Certainly your specialty, as you have frequently looked at echocardiograms, we can tell information about the lungs and one of the heart chambers that works with the lungs directly, right. if there's stress on the lungs from certain reasons. So there are other organs that are involved in addition to the heart that we can get an echo and get valuable information from.
Okay. Now, these sound waves, and I know something called the Doppler that goes along with it. You can actually hear the blood going through the valves and all of that kind of good stuff. It's pretty neat to listen to. But it comes back to a computer, and you actually see a picture.
You actually see a picture, and that picture, the patients always describe it. I heard something pulsating. I heard psst, psst. What that does, the sound waves are recorded in the old days was black and white, and now they're colors, the color pictures right. that actually can show the direction of blood flow the way it should go from point A to point B to point C. And if that direction is not carried out because there's an anomaly, there's something wrong with the heart, right. there's certain colors are created that tells us this is a leak. The valve is leaking because the direction of the blood flow goes in the wrong way. Right. And that's created in a certain predetermined color and then we can tell that is a problem. If the valve is too narrowed and too much pressure has to be created to go through that opening. Certain pressures are created that, again, the Doppler can determine, oh, this is a problem, the valve is not working well. So the Doppler phenomenon helps us a great deal to tell about valves, blood flow, is it the wrong way, is it too tight?
Right. Let's just step back for a minute, because there are patients that come in sometime and they just throw this word out, oh, yeah, I've had a murmur for, and I'm like, so what is a murmur? And they have no idea what a murmur. They just heard somebody say murmur, so now they know, hey, what is a murmur? So everybody will know what they're talking about.
So not every murmur, first of all, not every murmur is bad, but murmur is basically the noise that is made when the blood travels over a certain rough spot of the heart, or a small portion of the heart, or a hole in the heart, or through a clogged valve, or if the valve is leaking, the noise is made. Usually the heart is quiet. Usually the heart doesn't make a noise other than the so-called lub-dub that comes from the closure of valves. So the murmur, in addition, is blood flowing from one chamber to another, or one chamber through an opening, going through a hole that's not supposed to be there.
Right.
And noises are made, or sounds are made, that the doctors can tell there's something wrong. A lot of murmurs are heard. Sometimes they're benign. Sometimes there's no danger to the patient.
Benign means they're not dangerous.
There's not dangerous.
Right,
there's no risk to the patient. It doesn't bother them. They're fine. They've had it for years.
Right.
And sometimes there are murmurs that the doctor can tell that it needs further attention and that has to be worked on.
Right. All right. This is the one that always, everybody's talking about, my doctor said that I need a stress test.
So
tell me about the stress test.
So the word stress means that we want to stress your heart under controlled environment. We want to make sure that your heart is capable of functioning safely under a controlled environment in a doctor's office or in a hospital, where there are experts that just in case something goes wrong, things can be taken care of. So usually the most common reason for stress tests is to make sure that there's no clogged artery. The arteries are not narrowed from years of cholesterol and plaque buildup. Certainly the best thing is to prevent the disease, so you don't need a stress test. But if eventually a doctor thinks you have a stress test, means he wants to make sure that there's no clogged artery that's stopping the adequate blood flow to the heart muscle.
Right.
The stress test is done by hooking up to basically an EKG, and you run on a machine generally. Sometimes you can do a bicycle. Sometimes it's done without running, because the patients, without walking or running, because the patients, due to knee pain, due to leg pain from clogged arteries in the legs, due to lung conditions, they really can't walk. So the doctor gives them medication to circulate through the heart, and that acts as what we call a pharmacological stress test. It's done with medication. But the most common stress is you walk on a treadmill, you go through a predetermined time. Every 3 minutes, usually the treadmill goes higher and faster, and gradually the heart rate goes up, puts a little demand on the heart. And most people who pass it, they don't even bat an eye, they're fine. But if you get chest pains, or the EKG changes, or sometimes they add something called a nuclear pictures, a nuclear camera that can circulate to the heart to show clogged arteries, people can find out if there's a problem with the muscle, problem with lack of flow, and help the heart get better.
Interesting. So that really gives you an idea whether you have to go to that next step and actually look at those arteries around the heart to see if those arteries are open for that patient.
Correct. So the stress test, when someone is ordering it, they're actually thinking of a condition called coronary artery disease, the disease of the arteries of the heart, which we call the coronary arteries. Make sure there's no unusual clogged arteries. And sometimes they're clogged, they're a little bit clogged, but they're not critical, and you may pass a stress test. So you could have some plaque and it's not bothering you. We're looking for severe plaque buildup, severe narrowing that's not letting the adequate blood get through. So some people have minor narrowing, and they can be fine and just have continued control the diabetes, control the blood pressure, cut back on the fatty foods, cut back on the salt, exercise. But for those who just haven't had a chance to do that and they've gotten into trouble, the stress test can pick it up.
Oh, okay. All right then. Okay, I think are there any patients that can't tolerate a stress test? You know what I mean? Other than, just the knees and the shortness of breath. Are there any reasons you wouldn't do, like they have a particular disease or something that you wouldn't do it?
So generally, it's an excellent question. So generally you want to be believe it or not, you want to be on the healthier side to get a stress test. If you're very sick and your heart's in trouble, you certainly don't want to make the heart more stressful. You want to relax the heart. So usually a stress test is ordered by your doctor when you want to make sure you're okay and your health is up to it. The people who shouldn't have a stress test is when the heart muscle is too thick that it cannot function well under stress. There's some valve condition that the valve is too narrow, so if you push the heart, you can actually get lightheaded and perhaps collapse. There are some people who have dangerous irregular heartbeats, dangerous arrhythmias, and for you to stress them, they can actually get worse. People have certain lung conditions that if you stress them, the breathing gets worse, and you have to respect that. And sometimes even if you don't walk them, you give them the pharmacological treatment and medication, that also puts a burden on the heart. So you got to be very careful that the heart is not under strain at the time of the stress test. It's more for diagnosis, that we're not sure. If you're 100% sure the heart's in trouble, you'll probably bypass the stress and go to the next step. This is more for people that you're not sure, or you want to make sure that they're okay and they're safe to do it.
Well, what we're going to do is we're going to go to an aspect that I think is just most interesting. It's called the cardiac catheterization. Alrighty, and basically you're going to have to, the catheterization, you're going to have to tell me about this one. This is excellent. I love the word, number one, but it's a procedure that they do to actually understand what's happening at the arteries, what's going on with the arteries around the heart that supply the heart with blood. Tell me about this.
Correct. So cardiac catheterization, or sometimes referred to as angiogram, is a test that we want to outline the inner lining of the arteries. We can actually inject iodine or dye, commonly referred to, into the arteries of the heart very gently. Again, it outlines the inner lining of the arteries to make sure that there's no unusual blockage, to make sure that the arteries are where they're supposed to be. Sometimes some people are born with arteries in the wrong region. We can tell the location. We can check the strength of the heart muscle by also gently injecting the dye into the heart muscle. And make sure that that's strong enough and is pumping adequately. The catheterization, again, the patient gets to that step. Either they have unusual symptoms or very bad symptoms that is suggestive of a heart problem or a God forbid, impending heart attack. Or
now, when you start talking, let's get specific with these symptoms, because I want to know if I have it. You're talking about bad pain. You're talking about shortness of breath. Well, tell me about these symptoms. What symptoms are you talking about?
Correct. Unfortunately, the symptoms are many, but the common ones are pressure in the chest, tightness in the chest, burning in the chest. Doesn't necessarily have to be chest pain. An unusual heaviness in the chest. Sometimes it's felt as indigestion. It can move to the arms, mostly to the left, but it can also move to the right. It can go straight to the back. It can move to your jaw, and sometimes the heart's racing. Sometimes there's dizziness. Women's symptoms are not as clear as men, but there's dizziness, there's what we call palpitation, when the heart flutters, patient perceives or patient is aware of the heartbeat. Sometimes they feel faint, sometimes they feel tired. But once the patient knows that I'm not feeling right, there's something wrong, I wasn't like this yesterday, then they contact the doctor. In those situations when the heart's in trouble, obviously you bypass the stress test generally, and then the doctor thinks perhaps if the catheterization is beneficial to make sure there's no clogged artery. And then the decision is made to do the procedure.
Okay. Tell me about this catheterization. I know you brought some toys here with you. I'm just loving it here. And I want you to tell me, how is it done? Where in the hospital is it done? Does it take a long time? Does it hurt? You know, these type of things. You know.
Sometimes it can hurt, but we try not to.
Don't tell me.
So the heart is right here. The heart is right in our chest, and we got to get to it. So in the old days, the most common way that we got to it would be where we call the femoral artery, which is right in the groin. There's a right and left femoral artery, and very gently it's sterilized with a special cleansing solution. It's numbed, so the patient feels no pain. Patients get a little mild sedation, so they're comfortable, and the catheters are entered to the femoral artery. Just to add, we also do the procedures through the wrist. Of course, we have to check the circulation is intact. We can also sometimes do it to the upper arm or even different locations. No matter how you enter The heart, of course, the risks, all the risks are explained to the patient, the benefits are explained to the patient, the procedure explained to the patient, and after the patient reads the consent and reads the details of the procedure and agrees to it, the procedure started. It's always done in the cardiac catheterization lab. It's in a hospital setting. 99% of the time it's in a hospital setting. There's a whole team there, nurses, technicians, of course the cardiologist is there. Sometimes an anesthesiologist is required because patients are very sick. Mm-hmm. And when we enter the body, whether to the groin or to the arm, again, after localizing it with anesthetic material, mm-hmm. a small wire is put in, and a catheter is entered to the heart very gently. Right. The catheters are different sizes. If adjusted, basic catheterization, they're smaller. If you have to intervene right. and do something, catheters are a little bigger. Mm-hmm. But the purpose is to gently approach the heart and just get to the beginning of the arteries of the heart. Once we get there, gently the iodine is injected to the heart, mm-hmm. and we can take pictures. If a clogged artery is found, mm-hmm. Then we get to the so-called angioplasty mm-hmm. and stenting. So that's a very interesting field. In the old days, all we had was the balloon. Right. The balloon. Everybody has heard of the balloon. It basically is exactly what it says. A very small wire. Again, the catheter would reach the heart. A very small wire, such as this. If I can show this here. This wire.
All right, let me help you with this. Well, this is a very thin wire here.
Very thin wire.
Yeah.
It's almost like the wire in a light bulb. Mm-hmm. That would enter the catheter, mm-hmm. and it would exit here, it would go to the heart. All right. And once the blockage is crossed and once the problem is found, right. Now we got to fix it. Well, right. What do we fix it with? Okay. Then we go to our third tool here. Okay.
Well, we're going to have to wrap it up, though. Sure. I'm going to have to bring you back and we go through this sure. again. But what we're talking about is that we identify the abnormality in the vessel itself. And then from there, we can go ahead and either put the stent or we're going to open it up with the balloon and some. But we're going to have to come back and get to do this justice.
Absolutely.
All righty. Unfortunately, we've run out of time. But great. We're going to definitely come back. All righty. All right. In closing, because we're going to have to wrap this show up. All righty. Never institute any change in your medical therapy until you consult your physician. I trust each and every one of you continued good health. I'm Dr. Obey, and this is A Moment in Medicine. Until next time, peace to you all.